Deslandes, a professora Márcia Dourado e o professor Alexandre Valença por organizarem essa maravilhosa oportunidade de nós participarmos desse encontro com o professor André Veras, como a professora André falou, nosso egresso, uma pessoa muito querida e que continuamos trabalhando juntos, pesquisando juntos, e o professor Jeffrey Kahn, um longo amigo da Universidade Cornell, em Nova York, nos Estados Unidos, e que nós temos um contato muito estreito, trabalhos em conjuntos há anos, temos publicado, e o professor André Veras tem trabalhado de uma forma muito próxima ao professor Kahn, inclusive com o lançamento desse livro, que vocês estão vendo ali no slide, vou mostrar aqui, o livro está em minhas mãos, esse livro que foi lançado agora, Psychotic Disorders, que é um livro que fala em relação às comorbidades, a uma visão diferente dos transtornos psicóticos, a uma visão mais dimensional e não tão categorial dos transtornos psicóticos. O livro é dividido em 9 capítulos, são capítulos muito originais, porque abordam a psicose de uma forma única, e eu vou ler aqui alguns pontos que eu acho fundamentais em relação a esse livro, que pode ser encontrado na Amazon, e o professor André já me falou que está sendo feita também uma tradução para o espanhol, mas o livro é facilmente lido em inglês. Tem, por exemplo, a questão da comorbidade na floresta a comorbidade como uma das árvores na floresta das psicoses, que é algo muito interessante, mostrando como os sintomas psicóticos, as síndromes psicóticas, podem estar em diferentes quadros clínicos. Tem a questão do transtorno obsessivo-compulsivo e a sua relação com a psicose. Todos nós que fazemos clínica sabemos como esse limite do transtorno obsessivo-compulsivo, do pensamento e a psicose, como isso é algo muito discutível. Depois, é um capítulo muito especial, que eu tenho assim uma atenção muito grande, o professor Jeffrey Kahn também, em relação ao transtorno de pânico e esquizofrenia paranoide, assim como o transtorno delirante e a fobia social, o transtorno delirante persecutório, a sua relação com a fobia social. Eu tive o prazer de participar com a professora Laiana Qualiato e o professor Rafael Freire do capítulo sobre depressão delirante e melancolia, onde nós mostramos como é difícil e como é curioso tratar de pacientes com depressão e quadro psicótico. Não poderia faltar, um capítulo sobre transtorno bipolar, a mania e a depressão atípica, o uso de substâncias e a psicose, e, claro, doenças médicas em geral, e situações iatrogênicas e psicoses. Enfim, é um livro muito interessante que aborda de diferentes maneiras a relação da medicina com a psicose, em particular da psiquiatria, e hoje nós vamos ter o prazer de ouvir o professor André Veras e o professor Jeffrey Kahn. O professor André Veras é professor da Universidade Estadual do Mato Grosso do Sul, é um pesquisador na área de transtornos de ansiedade, psicose, tem uma série de publicações internacionais de grande importância, e o professor Jeffrey Kahn também. E o curioso em relação ao professor Jeffrey Kahn é que ele tem ideias muito originais a respeito do surgimento e da adaptação transcultural do transtorno de pânico, da fobia social, dos transtornos de ansiedade. O professor Jeffrey Kahn tem outros livros publicados, como o livro Angst, onde ele fala a respeito da ansiedade, a importância da ansiedade no desenvolvimento do ser humano. É algo muito interessante e único. Professor Jeffrey Kahn, it is a pleasure to have you here. I have introduced you and André Veras a little bit. You and him have a large curriculum. If I would talk about your curricula, I will stay here forever. And I have talk about your books, the Angst, yes, the Angst book. Now you can see the book. Nós podemos ver o livro Angst, um livro muito original e que tem até, como vocês veem ali na primeira palavra, a importância da cerveja na formação da nossa sociedade. Essa questão da cerveja, da fermentação do trigo participando da formação da nossa sociedade, virou um artigo que foi publicado, um editorial, no New York Times, e que é muito interessante. É só colocar o nome do professor Kahn, cerveja, New York Times, que vocês vão poder ler esse editorial muito curioso. Mas, sem me alongar demais, vou passar a palavra ao professor André Veras, que irá conduzir o trabalho. Professor André Veras, por favor. Obrigado.
Obrigado, professor Antônio Nardi. É um imenso prazer estar aqui como egresso da instituição, trazer amigos como o professor Jeffrey. E nós iniciaremos com a explanação dele, né, sobre a sua obra e sobre um dos capítulos desse livro. Como o professor Nardi colocou, cada capítulo aborda uma relação específica de comorbidades com a psicose, e nós elegemos duas comorbidades nas quais eu e o professor Jeffrey trabalhamos mais diretamente e contribuímos mais diretamente também nesse livro, para ilustrar como que a gente percorreu a relação entre psicose e ansiedade. So, Professor Jeffrey, we are very glad to have you here. Thank you so much. Now, I think we can start with your presentation, and as we have some delay, as we had some delay in our event, I think we can, after the beginning of the presentation about your books and about our book, we can go forward with your presentation, and then I will present the second part, talking about social anxiety. Is that okay? Your microphone is off, Professor.
Okay, I think I'm back. So,
yeah.
You would like me to present both parts of my talk now, and then you will talk?
Yeah, I think we can go ahead with your entire presentation.
Okay.
With no interruption, and then at the end, I keep going. Okay.
Okay.
So,
thank you so much to Professor Veras and Nardi for inviting me to talk. It's a delight. I've never spoken in Rio before. For what it's worth, my father did business in Brazil for many years and visited 2 or 3 times a year. That was a long time ago. But I'd like to begin by saying como vai, and I hope that is understood because the rest of my talk will be in English. Professor Veras asked me to start by talking about the origins of the psychosis theory that we'll be talking about today. And it began with the book on evolution. I was flying home from a trip overseas and reading a book about beer. And as I was falling asleep, I wondered, why would beer have been so important to ancient man 10,000 years ago? And when I woke up, I had the thought, well, maybe it was important then for the same reasons that it's important now. Here was our first psychopharmacological agent. It treated social anxiety in particular. There's actually research that says that alcohol is a specific, if temporary and dangerous treatment for social anxiety, and that's why people drink in bars and at cocktail parties. But it had the effect of overriding social instincts in the form of social anxiety, which is a proxy for biological social hierarchy, which is found in many species. Which led me to think, well, what diagnoses are common in my practice? And there are 5 specific subtypes of anxiety and depressive disorders that have been commonplace in my practice over the years. Each one in the book Angst appears to correspond to a primeval altruistic instinct. Altruistic in the sense that it's helpful for the kin group, although it's limiting or painful for the individual. But the advantage of these primeval altruistic instincts are that they help the group survive, and they allow DNA to survive and expand. Evolution, of course, is about the survival of DNA. Next slide, please. While writing that book, I had some initial thoughts about psychosis. I had done some work early on, a long time ago, with a famous psychiatrist in New York called Donald Klein, who's known to some of the people on this meeting, on the use of alprazolam for treating schizophrenia with comorbid panic attacks. And it worked quite well. There was additional and significant improvement in positive symptoms like voices and in negative symptoms like social withdrawal. And it occurred to me that maybe there are psychotic forms of each of the 5 diagnostic subtypes and their corresponding instincts. But those diagnoses are common and psychosis is not. So there is a growing and existing literature on the notion of psychotogenicity or psychosis proneness, that certain factors make people more prone to psychosis. There are many factors that have been identified, but 2 of the most, I think, useful to think about are something called hypofrontality, which is when the frontal lobes, where we do our conscious thinking, are not as effective in controlling underlying instincts and in increased dopamine activity. Dopamine, as we know, is very involved in psychosis. So when there's an interaction between these 5 comorbidities and their primeval instincts and psychotogenicity, perhaps that's what leads some people to become psychotic. And if you treat the comorbidity and the psychosis with the neuroleptic, and the comorbidity treatments are very specific, it's not any treatment for the comorbidity, people do much better. And this is something I've been doing in my practice in varying degree for more than 30 years. And increasingly finding ways that there are people that get much better and often get back to their baseline, their usual selves. So that brings us to the next book. André, next slide. Here's the Psychotic Disorders book, which is an edition which André and I edited with many contributors, roughly half Brazilian and the other half. And we had a bicontinental collaboration which led us to a good deal of thinking about the relative merits of cachaça and Kentucky bourbon. The title of the talk, this particular talk, is not about the book as a whole, but about the chapter. The book includes chapters on each of the 5 subtypes that we talked about. I'll be talking about.
I'm sorry for interrupting, but we are having some problem with your sound. It's going on and off, and I don't know if we try another microphone, maybe without the headphones, it may get.
How long has it been going on and off?
A couple of minutes.
Okay.
We can understand, but sometimes it get worse. So
I will move the microphone a little closer to me, and let's try that first, and see if that helps. And let me know if it continues to be a problem. I don't have a good substitute handy. The microphone is in the computer. It's not in my headset.
Okay.
So I'll be talking about panic anxiety, a form of anxiety. André will be talking about social anxiety. And there are other chapters on melancholic depression and atypical depression. These are subtypes of major depression, and one chapter on OCD. There's also discussion of psychotogenicity and other factors that are important to this theory. Next slide, please. I think the disclosures here are important. It's required in the US, and I think that the last disclosure is of greatest interest to this audience. I'm hoping that you're laughing, but I can't hear you. These are the 5 subtypes that derive from the group in angst, and the corresponding psychoses, melancholic depression, is associated with delusional or psychotic depression. This has long been recognized. This is not new. There's extensive work by 2 of the experts on the notion of a schizoobsessive disorder, a psychotic form of obsessive-compulsive disorder, and on persecutory or paranoid delusional disorder, which is work that André started and that we've also collaborated on. And last is some of my own work, which has been on panic psychosis, which I think can be also thought of as schizophrenia with voices. As we'll talk about, we've published on the notion that the auditory hallucinations, the voices in schizophrenia, are actually psychotic panic attacks. They're hard to recognize, and we have developed a specific way, a structured interview, which you'll hear for getting at that. Next slide, please. André? Are we still here? Okay. Panic anxiety has long been described in schizophrenia, and there have been many studies of comorbidity. A famous American study, the ECA study, found 45% comorbidity of schizophrenia. This may be an underestimate because in patients with active voices, the panic attacks may not have been detected, since they would have appeared as voices instead. Other research shows that the presence of panic is increased symptoms and disability in schizophrenia. And it's important to note that panic anxiety in our own experience almost always precedes the onset of psychotic symptoms. It is not that schizophrenia causes panic, because the panic disorder begins first before the schizophrenia does. Next, please. Panic attacks, as you might know, they're sometimes more subtle to diagnose, but there's the sudden onset of panic. Sometimes patients describe anxiety, fear, accompanied by certain sudden physical symptoms which occur. In addition, people with panic attacks have, without realizing it, they're anxious all the time, wondering what they're anxious about, but they're actually afraid of future panic attacks. And that's called anticipatory anxiety. It's not panic itself, but it's caused by panic. Panics are considered to be the primary cause of phobias, and they're not due to phobic exposure itself. Panic attacks only happen in some people. As we'll discuss in a moment, panic attacks can be triggered in the laboratory with natural chemicals such as lactic acid infusions or breathing carbon dioxide, but they only trigger panic attacks in people who have panic. In control groups who have never had a panic attack, those kind of challenge tests have no effect. There's no panic and no anxiety. Next slide, please. If I'm talking too fast, considering we're working in two languages, please let me know and I'll slow down a bit. Is the sound getting better?
No, not so good, but I think we can understand.
Okay. So I'll try talking a little louder. I don't know if that will work.
Yeah, maybe it will work a little louder.
Okay. So I'll pull my computer up close. Panic disorder is difficult to diagnose in schizophrenia. There have been, aside from the epidemiologic studies, there's been little attempt to diagnose panic attacks on the clinical level. One of the reasons is that panic and other anxiety and depressive symptoms seem unimportant compared to other problems. I've had many doctors tell me, well, of course they're anxious and depressed. Wouldn't you be if you had schizophrenia? The problem with that logic is that if you look carefully at the syndromes and the diagnoses of the comorbidities, they begin before the psychosis does. So that makes it unlikely that those symptoms are caused by the psychosis. But it's still possible that the psychosis makes them worse. There's an old story in consultation liaison psychiatry about the psychiatrist who goes to the oncologist and says, "Your Mr. Smith is depressed." And the oncologist says, "Well, of course he's depressed. He has cancer." And the psychiatrist says, "Well, if I had cancer, the last thing I'd want would be depression." With panic disorder, the same, and the other diagnoses, the same logic holds true, except that in addition, they precede the onset of the psychosis. Other reasons why panic is difficult to diagnose is because of paranoia, lack of willingness to participate, cognitive impediments, and agitation, and overlap with other psychotic symptoms as well. Next slide, please. Panic disorder in the literature is associated with increased treatment service utilization, with hostility, with suicidality, and with substance abuse. And as we talked about, there's the sudden onset of panic is associated with auditory hallucinations, and Sam Cyrus reported, and I've seen on occasion, it's also can be associated with the sudden onset of an increase in paranoia. Next slide, please. A study that Don Klein and I did many years ago was on using alprazolam to treat schizophrenia with comorbid panic attacks on the global benefit that we talked about. It's important to remember that only clonazepam or alprazolam, given on a fixed dose every 12 hours for clonazepam, every 6 hours for alprazolam, are effective for treating panic and at the same time diminishing psychosis in schizophrenia or in schizophrenia with voices. These are the only two that in the United States are approved by the federal government for panic disorder. And other benzodiazepines do not have the same usefulness in treating psychosis with panic disorder, even though they're commonly used for schizophrenia. As we've talked about, they can be very effective. Some patients will get back to their baseline and stay there. My longest follow-up was a woman who stayed non-psychotic and fully functional for years until she moved to another state about 10 years ago, and I've not had contact with her. But I don't doubt that she's still doing well. Next slide, please. People have many concerns about benzodiazepines, which are non-specific concerns about benzos in general. I think those concerns are overrated. Some of them have been disproved. I've treated many psychotic and non-psychotic patients with panic disorder with clonazepam, and I have never had someone develop abuse problems. There is a physical addiction that can develop, but that simply means that people have to be stop. Yes. Antonio? Antonio, your microphone is on. Okay. Should I continue here?
Yes, please.
Okay. Except in elderly or patients with central nervous system problems, I have not seen impaired motor performance. I've never had a patient fall. I've seen improvements in cognition, never a reduction. There is an initial drowsiness that happens with clonazepam. Other than that, I've seen only a little bit of mild long-term sedation. It's worth noting that research has shown that benzodiazepine users, now this is all benzos, have increased service use and more time in the hospital, but the causality is not clear. Is it that benzodiazepines cause a need for greater treatment, or is it that they're used as a last resort in patients who in fact are more difficult, so that benzodiazepines are a marker for more difficult to treat patients? Next slide, please. Are you able to hear me better now?
Yes, much better.
Okay, great. André and I have put together a plan for a project or series of projects that would look for a way to better delineate panic disorder and schizophrenia, and what we have called a panic psychosis as a better description of what we think this is. Identifying clinical subgroups and the phenomenology, looking at specific psychotic symptoms that may be associated with panic and psychosis, using diagnostic challenge procedures such as a clinical diagnosis and for treatment response assessment, using the carbon dioxide challenge to examine neuroanatomical function with fMRI, because we should be able to trigger voices at a specific time, which is a problem in fMRI research, by using a CO2 challenge. I had previously developed the panic and schizophrenia, which we call the PASI, which is a way to take a comprehensive history of panic in schizophrenia, and in particular by examining the sudden moment when voices begin, and looking for panic symptoms. Next slide, please. So here's what we talked about before about challenge tests. Carbon dioxide is the simplest, safest, and most widely used test now. So you ask patients to inhale for 30 seconds a mixture of 35% carbon dioxide and 65% oxygen. So it is the increased carbon dioxide that is triggering panic, not oxygen deprivation. There are other challenge tests that have also been shown to work. I know that the group in Rio has used some of these tests, including the caffeine challenge test. When you use a challenge test on a patient who has known panic attacks, we're talking about non-psychotic panic patients. About 70% will panic on any given try. On controlled subjects who've never had a panic attack, the panic rate is about 0%. These are very brief tests. They're safe. There are no side effects, and there's no need for an IV. It's notable that panic attacks can be prevented in challenge tests with adequate doses of clonazepam, alprazolam, and tricyclic antidepressants, but probably not by cognitive behavioral therapy. Patients who've had highly effective CBT will still panic in response to it. Next slide, please. Adam Savitz and I did one study on carbon dioxide in schizophrenia, and these were patients with schizophrenia who were recruited from the clinical wards at Cornell. So they were on various medications, and we did not select patients who were known to have panic or anxiety. That was ignored in selecting patients. Next slide. And we had certain goals. We found that this was safe in patients with schizophrenia. We also didn't have any patients who complained. The worst complaint was a patient who said, "Yep, I had another panic attack." And they didn't experience this as any worse or different than ordinary panic attacks. Bothered by, but used to. We also wanted to look at the value of this challenge in schizophrenia, and we wanted to compare it to the panic and schizophrenia and explore whether hallucinations are associated. And finally, we wanted to re-challenge patients after treatment to see if they still panicked. Next slide. This was a small pilot study. We only studied 8. And patients were carefully assessed. They continued on current clinical treatment. And for this study, we looked for, we only accepted patients who who were having ongoing auditory hallucinations on the theory that would give us an opportunity to study whether they were panic, but also on the theory that we thought it likely that auditory hallucinations were panic, so that was a better way of determining whether they were having ongoing panic, which appeared as hallucinations. Next slide, please. These are other inclusion criteria. Most of them are fairly standard, or we've already talked about. Next slide, please. Certain exclusion criteria for safety. And of the patients that were referred, about 5 out of 6 patients were excluded. Mostly, nearly all of them were patients who did not like the word research. I don't know how to say the word research in Portuguese, but I assume you know that word. And there are some patients, particularly those with paranoid, who don't like the idea of being involved in research. They think it's harmful, and they're afraid of it. So that group was not included. Next slide, please. Patients were familiarized with the procedure before it began. This was a randomized controlled study. The CO2 administering doctor, which was me, did not know on any given try whether I was giving the patient regular air through a mask or 35% carbon dioxide. There was the other Adam Savitz, the other psychiatrist. He controlled and randomized the order in which they were given. Each subject had 2 exposures, and their responses were measured using a DSM rating scale with a detailed review of psychotic symptoms as well occurring during that interval. Then the mask was removed and the patients. Same. Next slide, please. The panic and schizophrenia interview. We set the interview stage carefully. Remember that these are patients who are actively psychotic. They're cognitively impaired. So it's important to carefully. This is done after they've already given consent, informed consent, to set the interview stage very carefully so they know what's going on. To repeatedly refocus their attention on what they're doing so that with every symptom you ask about, for example, panic symptoms, at that same sudden moment, did you feel your heart going fast? At that same sudden moment, did you feel short of breath or like you couldn't catch your breath? Because if you don't refocus them, they will lose track of the fact that we're looking at the sudden moment that the feeling of panic or the voices came on. So it begins by working with the patient to establish those moments when voices come on suddenly. Many patients will say they always hear voices, but when you interview them carefully, you can, for example, you can help. But there are moments when they don't hear voices, even if they're always thinking about voices. And once they know that there are moments that they don't hear voices, then you can say, and when actually hearing the voices come back, is that very sudden? And they will almost always say yes. And that gives you a moment in time that you can look at to assess this carefully. Patients often have a psychotic understanding of where the voices come from, of course. And it's important to acknowledge that that's how it looks to them. But ask questions about the symptoms during the voices at the same time. Next slide, please. Here's an example of 2 slides that give an example about how the interview starts and how the stage is set. For example, do you hear voices at every moment or only at certain times? Acknowledging that there may be the reasons the voices start talking to you when they do. But when they do begin speaking, for whatever reason, is it all of a sudden? Or did they start softly and steadily get louder? Or are there times when they're ongoing but suddenly get louder? Next slide, please. And this is the second part of the introduction to the passage. And say, okay, let's talk about that sudden moment when the voices begin or intensify or become obvious, even if you know the reason why they start. And then you further go on describing how you're going to ask about the symptoms. Now you're only interested in those symptoms that happen, the sudden moments that the voices come up. Next slide. I did put the whole passage on slides, but it's many slides long. It covers a lot of ground about past history of panic and current history, all of which is important, as well as a full list of DSM systems, as well as some test symptoms and challenge symptoms, which examine for false positives and false negatives. I didn't include that here. The entire passage is in the book for those who want a copy, and of course, none of the patients that 8 patients that Adam Savitz and I studied had previously recognized panic attacks, even prior to their psychosis. All of them had the passage before the CO2 challenge, and all of them screened positive for panic and for voices happening at the same time on the interview. So the interview supported the idea that the voices were psychotic panic attacks. All of them panicked to carbon dioxide. One of them also panicked to placebo room air. And all patients were back to baseline within a minute of the CO2 cessation, most of them within 15 seconds. All of the patients were on the medications that they were on clinically, and only one subject panicked in response to the CO2. During a previous single patient study, a patient who was not on medication, many years before, they also panicked and heard voices in response to CO2. But most of them were on medication at low doses that had some anti-panic. So it could be that the ability to induce voices rather than just panic attacks was diminished because nearly all of them were on some form of anti-panic medication. There was one patient who was not on any anti-panic and did hear voices in response to the carbon dioxide challenge. Was treated with adjunctive clonazepam, 1 milligram every 12 hours, gradually increased to that level. Their voices continued to be gone, and they had a significant clinical. Unfortunately, the patient was discharged from the hospital because she had improved so much before we had a chance to do repeat challenge. Next slide, please. So basically, carbon dioxide challenges are safe in schizophrenia, and patients are not bothered by them. Next slide, please. The carbon dioxide challenge is highly effective in schizophrenia. This did not allow us to study carbon dioxide-induced panic or voices in a wider group of schizophrenia, but even in this very small sample, it hints in the direction that most patients with schizophrenia and voices, if not all of them, have panic attacks and probably concurrent panic and voices. The panic and schizophrenia interview was effective. It documented the concurrence of panic and voices, and the results in terms of panic were the same as in the CO2 challenge. Okay, next slide, please. We would like to be able to do more CO2 challenges in patients, if possible, and ethical, who are free of anti-panic medications, and look for, use it for dose ranging also, to find out what doses are effective, besides clinical experience, which we already have. There's a great deal of clinical experience that expands these findings, and we can work from other researchers that also expands in the book. This is some work that we have done ourselves. It's notable that of our 8 subjects, 4 of those subjects were taking low doses of clonazepam and nonetheless panicked in response to carbon dioxide. So those were clinically what would have been insufficient doses. And 5 subjects, there was overlap here, were on SSRIs. SSRIs, while they're commonly used to treat panic, do not seem to have additional benefits in patients with schizophrenia and panic. And they all panicked despite being on an SSRI. Next slide, please. There's more work to be done, and we're hoping, André and I, to develop that might pursue some of this research in Brazil and in the United States and maybe elsewhere. And there's a great deal of ways that this work can be taken in many different directions. But the most important is looking at treatment effects and documenting the value in open studies, but if possible, in randomized controlled studies. This has been a dream for some time. I don't know how funding works in Brazil, but the United States government has for many years now basically stopped funding clinical research. So funding in the U.S. has been hard to find. Next slide, please. André, the next slide is not there right now.
Can't you see the next? I'm in this published pilot study, schizophrenia.
Okay, it just appeared. We are far away. It took a while to get here. A study that Dr. Veras, Professor Veras, conducted in Campo Grande, started out as a multi-centered study in 3 continents, but André actually followed through. And he identified 20 Brazilian patients with DSM-5. These were a clinical sample, and he used a very careful evaluation to look for the kinds of comorbidities that we've been talking about. And he found them that in this randomly selected clinical sample, all of whom met DSM-5 schizophrenia standards. The theory was that one of the 5 comorbidities, and maybe more than one, would be found in most or all of the subjects, and that's what he found social anxiety in 5%. That's actually lower than has been found in some other studies, but there could be a reason for that. Because of André is less likely to confuse schizophrenia with persecutory delusional disorder, as he will show you in his talk. So if those were excluded, then you would expect the level of social anxiety in the sample to go down. 60% of this sample had panic anxiety, and if you include voices as being panic attacks, the rate goes up to about 80%, suggesting that most of these patients with schizophrenia had panic disorder. 15% had obsessive compulsive disorder, and major depression, atypical depression, and melancholic depression, unfortunately, had to be lumped together in this study. They were about 15%. So in total, 80% or more had at least one comorbidity. And it's important to note again that just as in non-psychotic patients, if you have a patient with panic disorder, for example, there's about a 2/3 chance they also have an atypical depression. There's a high rate of comorbidity among these 5 anxiety and depressive subtypes. You might expect to find that in the psychotic version as well. So you see many patients with multiple comorbidities. I'm treating a patient now who presented with psychotic mania, and she had mania, she had atypical depression, she had social anxiety, and she had panic disorder. She was in pretty bad shape. But she's now virtually free of psychosis. There's still one fading delusion because all of the comorbidities have been treated in her. Rather than just treating the mania alone, which is what was done in the hospital. He came out of the hospital treated by someone else on anti-manic drugs alone, but still quite psychotic. But by adding in medications for her several, she got better and better, and is now pretty much back to herself. And in some ways, she's doing better than before she ever had a psychotic episode. For example, because she no longer has panic attacks, and in her case, social anxiety. This was someone with severe social anxiety before psychosis. Next slide. How do you treat schizophrenia with voices, or what we call panic psychosis? Here too, there's a much lengthier discussion in the book. The chapter in the book on panic psychosis or voices is far more detailed in all of the areas we've talked about, and includes other research that's relevant, research and genetic studies, as well as treatment approaches, fictional case studies, and other things. It's very important in any psychotic patient to use a neuroleptic. That's where you start. Generally, soon after patients are stabilized, you may be able to get the history of comorbidities while they're active. André and I have had a lot of experience at that, so we know the hints to look for. But it's easier to get a history after they're stabilized a bit and are more cooperative. There is some research that was published using clonazepam in the emergency room in addition to a neuroleptic, and found that the patients stabilized faster and better and with lower neuroleptic doses if they were also given clonazepam. This was not a group that was selected for panic or voices, but selected on the basis of just agitation. In our experience, clonazepam should be given every 12 hours, sometimes every 8 hours, but not used on an as-needed basis. Rather, you start at a low dose because of initial drowsiness, and you raise the dose gradually as the drowsiness, generally in 3 to 10 days. And then you keep raising the dose until panics and voices are fully gone. A typical end dose is 1 milligram to 2.5 milligrams 12 hours. In other words, 2 milligrams to 5 milligrams total daily dose, given Q12H or Q8H. And patients often show a remarkable improvement. There are some cautions here. One is that patients are often apprehensive as they improve. They often complain of severe drowsiness when they don't look or act drowsy, and want to stop the medication. This is something to discuss with them in supportive psychotherapy. And they're probably reacting both to an exaggerated perception of real drowsiness, but also to concerns about the illness itself, and a growing realization that they had a serious problem with long-term consequences. The panic is not a temporary medication, it's a long-term one. In the long term, you can often reduce the neuroleptic and reduce the odds of tardive dyskinesia and other neurological consequences. But only infrequently can you stop the neuroleptic completely. You usually need to maintain at least some of it. Next slide, please. So there's a more detailed discussion in the book. There's the title, there's a photograph of the book. So as you're flipping through the pages on Amazon and you see that, you know that you have found it. I would like to thank you all for listening. I hope that the internet worked well enough. I'm happy to take any questions, and I appreciate your attention. If anyone wants to contact me, here's my email address.
Thank you very much. Thank you, Jeffrey.
You have 2 connections.
Thank you very much, Jeffrey. And I would like now to start with André. André, please, your presentation. Thank you, Jeffrey.
Thank you, Professor Jeff. It was a great pleasure to hear your points on panic and psychosis. Então, vamos seguir com a proposta era que nós continuássemos com a apresentação sobre uma outra comorbidade, que é a ansiedade social, relacionada à psicose. Como tivemos um pouquinho de dificuldade no áudio do professor Jeffrey, eu vou iniciar fazendo uma breve síntese daquilo que foi explanado. Acredito que uma porção razoável do conteúdo foi compreensível, uma vez que os slides também eram bastante explicativos, mas, em síntese, o professor Jeffrey apresenta um dos capítulos que nós discutimos no nosso livro, como está colocado aqui no nosso índice do livro, né, o capítulo sobre a esquizofrenia com vozes e o pânico. Então, centralmente, depois de apresentar a trajetória da sua obra da relação entre pânico e psicose, o professor Jeffrey apresentou alguns estudos que vão na direção de revelar, né, que o pânico é mais comum do que a gente observa na clínica na esquizofrenia, e ele fez isso através tanto do desenvolvimento de uma entrevista clínica sobre o pânico, como através da descrição fenomenológica do pânico na esquizofrenia, como também através da indução de crises de pânico psicótico em pacientes com esquizofrenia, que, como ele apresentou, acontece com uma significativa frequência, e essa indução com uma mistura de CO2 na psicose tende a produzir, além das experiências que a gente observa num paciente com pânico, com uma crise de pânico, também o aparecimento súbito de vozes. E isso coincide com a descrição fenomenológica que ele apresenta do pânico na esquizofrenia ser expressado dessa forma, com um súbito aparecimento de vozes, normalmente vozes que vêm acompanhadas dessa série de sintomas tradicionais no pânico. Então, são vozes paroxísticas, né? Essa é uma característica, então, interessante para que o clínico esteja atento e se utilize disso como um sinal da necessidade de aprofundamento da investigação dessa comorbidade na esquizofrenia. Depois, então, ele apresenta também um outro ensaio piloto com o bloqueio dessas crises, né, dessas vozes paroxísticas e das sensações de pânico em pacientes psicóticos com o uso do alprazolam e do clonazepam. E o desfecho da apresentação vai no sentido de direcionar, né, esse diagnóstico de uma comorbidade como o pânico, direcionar um tratamento melhor, mais aprofundado, que também leva em consideração esse aspecto, tanto as experiências gerais de pânico, físicas e psicológicas, como a eficácia da associação com benzodiazepínicos para a redução de experiências como as vozes, que, como ele conclui, podem auxiliar, inclusive, na redução da importância do antipsicótico para o tratamento da esquizofrenia, permitindo doses menores, que normalmente são mais bem toleradas e produzem menos efeitos colaterais tardios. Como a gente que trata a esquizofrenia, a psicose, sabe bem que é um risco do tratamento crônico. Então, seguindo nessa direção, nós temos, né, além de outras comorbidades, uma outra que também é trabalhada no livro, né, do transtorno delirante, um componente persecutório, e da relação disso com a ansiedade social, que é o que me coube apresentar aqui para a gente ilustrar todas as comorbidades que são discutidas no nosso livro. Então, nós sabemos que a ansiedade social tem relações, né, frequentes com sentimentos paranoicos, numa via de mão dupla, né? Tanto a paranoia, né, os pacientes psicóticos podem apresentar uma significativa ansiedade social em virtude da preocupação com ameaças e com um mau juízo das pessoas, como é frequente que pessoas com ansiedade social tenham também ideias de autorreferência, uma vez que muito ansiosas, muito preocupadas com o juízo dos outros e com as suas potenciais inadequações, ficam numa constante leitura desses juízos e muitas vezes desenvolvem ideias que transitam, né, do espectro da ansiedade para o espectro da psicose. Então, isso é bem descrito na literatura, né, que os pensamentos, comportamentos e crenças centrais de indivíduos com um transtorno de ansiedade social podem se apresentar como crenças psicóticas. E na esquizofrenia, com frequência, nós temos essa comorbidade, a ansiedade social, com uma frequência semelhante a outros transtornos, como o transtorno de estresse pós-traumático e o transtorno obsessivo-compulsivo. Então, essa prevalência na psicose, ela é significativa e, portanto, é uma comorbidade importante de ser considerada. A ansiedade social, então, está entre as 5 comorbidades mais frequentes na esquizofrenia, como a gente descreveu em cada um dos capítulos do nosso livro. E também é bem descrito na literatura que a ansiedade social pode se configurar como um diagnóstico prévio, muitas vezes até um fator que antecede a psicose, né? Um fator potencial de risco, no sentido de que alguém que tem uma vivência de ansiedade tão frequente e cotidiana e constante, especialmente nas relações sociais, tem um fator estressor, no mínimo, né, um fator estressor que pode facilitar a ocorrência de transtornos mentais mais graves. Então, como a ansiedade social muitas vezes antecede a psicose, a esquizofrenia e, bom, também os transtornos que são do espectro da esquizofrenia, né, como o transtorno delirante, muitas vezes ela aparece como uma comorbidade. E muitas vezes porque ela já estava presente, e não é porque a pessoa abriu um quadro psicótico que ela vai deixar de ter ansiedade social. E também é descrito na literatura que indivíduos com esquizofrenia e ansiedade social tendem a apresentar uma maior preocupação, né, de experiências como que os outros estão ouvindo seus pensamentos, ideias de referência, e isso repercute, essa gravidade sintomática muitas vezes repercute também no sentido de aumentar a gravidade de comportamentos, como tentativas de suicídio, um maior embotamento, uma maior reclusão por baixa autoestima e um pior funcionamento social e uma piora da qualidade de vida, representando então a importância de identificar essa condição comórbida para um melhor manejo e um melhor tratamento consequente. Então, vou apresentar de uma forma bem sintética alguns artigos que nós publicamos em conjunto, inicialmente um artigo que faz uma descrição fenomenológica dos sintomas psicóticos em pessoas com ansiedade social, então identificando essa via, né, da ansiedade social, podendo se apresentar ao longo do seu desenvolvimento com sintomas psicóticos, com muitas ideias de autorreferência, com uma experiência grande de inadequação, que transita, né, fica oscilando entre a ansiedade, com mais insight, e a psicose, com menos insight sobre essas crenças. Esses casos foram acompanhados por um longo período, né, e o que nós descrevemos, aí já em parceria com o professor Jeffrey, a transformação da ansiedade social em uma nova categoria, né? Um transtorno delirante persistente. Ou, se a gente for mais flexível em relação aos critérios diagnósticos, uma ansiedade social que fica psicótica, uma ansiedade social que aparece com sintomas psicóticos. Nós discutimos isso também no nosso livro, né? Há algumas comorbidades que permitem que sejam diagnosticadas com ou sem sintomas psicóticos, como é o caso da depressão, como é o caso da mania. Mas na ansiedade social, os nossos manuais diagnósticos não abarcam isso, né? E acabam fazendo com que a identificação diagnóstica muitas vezes seja entendida como uma outra categoria, quando muitas vezes o que a gente vê é uma ansiedade social com sintomas psicóticos. Mas como nos nossos manuais da psiquiatria a gente não tem essa alternativa, então muitas vezes isso acaba sendo diagnosticado como um transtorno delirante persistente. Então, do ponto de vista evolutivo, a gente descreve então a fenomenologia, a dinâmica dessa transformação da ansiedade social numa psicotização, numa ansiedade social psicótica. E num dos artigos que o professor Jeffrey citou na sua apresentação, nós avaliamos de forma bastante pormenorizada um grupo de pacientes com a intenção de identificar todas as comorbidades existentes. E nesse artigo nós fazemos uma síntese da apresentação fenomenológica e das relações clínicas entre essas comorbidades e a psicose. Mais especificamente sobre a ansiedade social, o que a gente observou é que os pacientes com ansiedade social, né, do ponto de vista fenomenológico, a apresentação clínica tende a ser se a gente for buscar na história, de pacientes que já tinham uma ansiedade social prévia ao aparecimento da psicose, e a psicose desses pacientes, ela acaba sendo mais focada no que a gente chamaria de figuras de autoridade, né, figuras ameaçadoras, como perseguidores, a Polícia Federal, ou as suas versões mundo afora, né, de figuras de autoridade, com comportamentos que tendem a ser de maior insegurança e de maior submissão, e com um prejuízo no campo social, com ideias de referência e uma tendência a uma reclusão maior, né, com mais sintomas negativos, com mais reserva social. Então, nesse artigo, nós apresentamos as características dessa ansiedade social na psicose, também com a intenção de contribuir com a identificação dessa comorbidade, passando desse primeiro diagnóstico, né, de psicose ou dos transtornos do espectro da esquizofrenia para um nível um pouco mais profundo, né, um segundo eixo diagnóstico que nos permite identificar as comorbidades e dessa forma aperfeiçoar os tratamentos. Então, da mesma forma como o professor Jeffrey colocou, da importância de identificar uma comorbidade com o pânico, se tratar essa comorbidade, uma vez que isso vai repercutir tanto nos sintomas do próprio transtorno de ansiedade, mas também nos sintomas psicóticos. No caso da ansiedade social, a gente pode fazer o mesmo raciocínio. Identificado um transtorno de ansiedade social, é preciso, além, né, do uso dos antipsicóticos, também dar um tratamento apropriado para essa comorbidade, utilizando, por exemplo, os inibidores seletivos de recaptação em associação com os antipsicóticos e realizando a psicoterapia necessária, né, para esse aspecto fóbico que é peculiar da ansiedade social. E, da mesma forma, né, a associação dessas tecnologias de tratamento, ela não vem no sentido de aumentar o número de medicações ou aumentar o peso do tratamento. Pelo contrário, vem no sentido de ampliar os recursos de tratamento, na medida que a gente amplia, né, as identificações diagnósticas, para poupar o indivíduo de tratamentos que tendem a ser mais pesados, né? Ou seja, se nós centramos o tratamento nos antipsicóticos, entendendo que todas as condições de alguém que tem uma psicose são decorrentes desse transtorno apenas, a tendência é que a gente use doses de medicações que são normalmente de tolerância mais custosa, mais difícil, e às vezes até que agravam alguns aspectos do espectro da psicose, como, por exemplo, a sintomatologia negativa, como nós sabemos. Esse tratamento tem que ser visto também de uma forma longitudinal, e a tendência é que o tratamento adequado das comorbidades reduza a gravidade, melhore a evolução e nos permita gradualmente poupar o paciente ao longo da sua fase de manutenção, na continuidade do tratamento, de um uso de doses elevadas de antipsicóticos e também, claro, permite o paciente que, no sentido de uma reabilitação no campo psicológico, no campo social, ele tenha maiores ganhos e com uma maior efetividade da direção terapêutica. Então, espero que tenha sido compreensível e proveitoso para todos, e nos colocamos agora à disposição para qualquer pergunta que poderá ser traduzida para o professor Jeffrey sem problema nenhum. Obrigado, professor.
Nós aqui agradecemos você também, professor André, pela excelente apresentação, por esclarecer alguns pontos já mencionados pelo professor Jeffrey. Professor Jeffrey, thank you very much. As you might know, this presentation is transmitted by YouTube, and we have received many people congratulating you for your presentation, your original ideas, your great explanation. And we have some questions for you. Of course, we do not have time for all the questions. I will try to summarize many questions in one question. They ask if you could please suggest some points that should be observed for the new classifications of mental disorders, because they congratulate you for your clinical point of view. They say here that what you have explained and showed to them is what they see in the clinical practice. But what do you suggest for new classifications? And they would like also if you could talk a little bit more about the use of benzodiazepines in psychosis, please.
Well, one of the organizing structure of the book is based on the notion that much of functional psychosis, I don't know how you say functional in Portuguese, but it basically means idiopathic, unknown physical cause. So much of functional psychosis can be understood as psychotic forms of specific comorbidities. There are 5 of them that appear to account for most of psychotic disorders, not including physical psychoses such as those caused by medical illness or drug abuse. So the idea is that that might be a more useful classification of psychosis than currently exists. Which ones are they? Well, psychotic depression as a psychotic form of melancholic depression has been well recognized and the treatment well recognized for decades. So that's not new. Both social anxiety and persecutory delusional disorder have been known for a long time, but that they are connected is relatively new. And that work was started by Dr. André and yourself. And so that would be a second group, that a psychotic social anxiety disorder. The notion of a psychotic form of obsessive compulsive disorder goes back 10 or 20 years, and there's a considerable literature on it. It was considered by DSM-5 for inclusion, but they decided not to include it. And then there's the notion of a panic psychosis. We first mentioned the possibility more than 30 years ago, but possibly because of concerns about benzodiazepines, there's been not enough research on it since then. But that would be a fourth group of idiopathic functional psychosis, panic psychosis. And lastly, mania with its delusions of grandeur and religious delusions, is often thought of as a psychotic disorder. And it may be a fifth kind of comorbidity psychosis, but with a different relationship. In all five of these diagnoses, some of the main underlying psychotogenetic factors are present. They're also present in people who have bipolar 1 mania. But one of the differences is that in the other four cases, there's an existing and syndrome such as social anxiety, which can become psychotic in the presence of those underlying psychotogenetic factors. With bipolar disorder and atypical depression, the relationship may be different. I've wondered about a psychotic form of atypical, and I think I've seen it, but I'm not sure. I think the relationship between the two, bipolar 1 mania and atypical depression, is that most of the depression in bipolar 1 disorder is atypical depression, and they appear at different times. They're both seasonal, at least to a large extent. Atypical depression is worse in the wintertime with short daylight hours, and it's related to seasonal affective disorder, which is a form of atypical depression. Mania is, especially the first episode, is more common in the springtime and in the summer. So we have put forward the theory that this evolved from an ancient hibernation strategy, where atypical depression has symptoms that are similar to those of hibernating animals today. And mania is similar to the symptoms, an exaggerated version of the symptoms of animals waking from hibernation. And there's more about that in the book as well. And there's literature to support this. Anxiety can be treated with light therapy. And in studies done mostly in South America, you can augment treatment of lithium with dark therapy in various ways, which goes along with seasonal light variation in hibernation theory. But there's more work that needs to be done. As far as benzodiazepines are concerned, when benzodiazepines are used carefully and appropriately, the risks are small. In someone who's an active drug abuser, you would be cautious. Personally, I only use clonazepam and rarely alprazolam, and only for panic disorder. I don't use other, and I don't use any benzodiazepines for anything else. I know you have done some work with a group on trying to demystify benzodiazepines for the psychiatric world. I gave a talk last week, and one of the participants was a psychiatric resident in California who was horrified when I talked about using clonazepam, and she said, at my medical school, we are forbidden ever to use benzodiazepines for anything. And I told her that she had a new mission, that she had to convert her medical school to logical thinking. And her response was that she smiled and she said, well, I'll think about it. I have treated hundreds of patients with clonazepam and alprazolam only for panic over several decades. I've never had a serious problem of any kind. But I am careful. In elderly patients, people with gait disturbances, CNS damage, you have to be especially concerned about sedation and gait disturbance with benzos. There are other times to be cautious too. But if you are, they are very safe and effective medicines. One of the concerns has been that they cause dementia. There was an editorial last June in the American Journal of Psychiatry and an article which actually supported the idea, first of all, that although benzodiazepines predict dementia, they don't cause dementia, and there's even a chance they may help protect against dementia. And this was featured in the top American Journal, along with an editorial that supported those findings.
Thank you, Jeffrey. Jeffrey, we have here a lot of questions, but as I said, we do not have time to ask all of them. But many people are very curious when I introduced you. I talk about the editorial that you published in the New York Times some years ago about beer and the start of our civilization. And they will look for it in the New York Times, but they are asking here if you could say some words. Why could beer help the start of our civilization, please?
Well, briefly, the New York Times was interested in the angst book, and at that time they had a weekly op-ed. I don't know if they use the same word in Portuguese. It's not an editorial, but it's an outside editorial. And they had a weekly section for an op-ed on science. And they asked me if I was interested, and I said, sure. And I gave them a bunch of ideas, and as soon as I mentioned beer, they said, we'll take that one. This is discussed in the book at greater length than in the New York Times, in the angst book. But basically the idea was, it's the title, if you want to look it up on Amazon, is How Beer Gave Us Civilization. Put in my last name and New York Times, and it should come right up. Basically, the idea was that beer was invented about 10,000 years ago. It had been thought that civilization started when humans learned to domesticate grains, and so they could become farmers and settle down and have a steady supply of food, and that some of the stored grains spoiled and they also had beer. But if you think about it, that doesn't make sense. What caveman would go to all that effort to domesticate grain and harvest it just to make bread when they had plenty of food around? And there's actually evidence that that wasn't what happened. That is the bread first hypothesis. There's also the beer first hypothesis, that grain was domesticated in order to make beer. And there is evidence for that. There are archaeological sites from 10,000 years ago that show evidence of beer making, but not of bread making. And it makes more sense that having discovered beer accidentally from fermenting fruits, for example, that humans would have gone to some effort in order to increase their supply of beer. There's also the question of where corn came from. Corn came from Mexico City, from the hills around Mexico City. It was one of the native grasses. It was, of all the native grasses there, it was the worst one. Teosinte, it's called, is the worst grass for making bread because it has few grains and it's very hard. But it's the best for making beer because you can ferment the whole plant. So the ancient Mexicans domesticated teosinte, not one of the more bread-friendly or tortilla-friendly grains, and it eventually became what we now know as corn. Alcohol, I think we already talked about this today. Alcohol has been shown in one study to reduce social anxiety in a clinical experiment. And we conduct that experiment ourselves when I and shy people and other people get together in a bar or at a cocktail party, and after a drink, everybody feels more comfortable with each other. It has a kind of temporary democratizing influence, particularly if you think of social anxiety as a form of social hierarchy. Everybody goes on the same level. And it may be that leveling effect that allows more equal discussions, more participatory discussions, and people were able to develop civilization. There's much more to the story, both in the Times article. I'll take credit for the contents of the article, but the editing by the New York Times editors was the best editing I've ever seen, so I can't take full credit for the writing. I wonder what the newsroom was like when they were editing that editorial, and what happened when they realized that they could publish on St. Patrick's Day. St. Patrick's Day, I don't know if you have that or know what that is in Brazil, but St. Patrick was the founding saint of Ireland who brought Catholicism to Ireland. And in the United States, it's an unofficial national holiday where everybody drinks beer. So they published the editorial on St. Patrick's Day. And it became the most read and most emailed article for the entire New York Times for 4 consecutive days. Not long ago, a new patient came to me who worked for a beer company, and she started talking about beer, and I mentioned this article to her. She said, "I know that article. Everyone knows that article in the beer industry. Did you write that?" I said, "Yes." She said, "Can I bring you back to the office and have you give a talk?" So,
yes, please.
Pardon?
No, you may finish. I would only like to say that I have sent this article to many, many colleagues around Brazil and the world. All of them love it. I have sent this article even for some relatives, and I am sure that it is the most read editorial ever in the New York Times.
I think it's a far bigger accomplishment than my professional career than it.
Thank you very much, Jeffrey.
Thank you.
André, eu tenho também muitas perguntas para você, mas o tempo já está muito avançado. Só uma pergunta. Alguns colegas querem saber se você continua nessa linha de estudo da relação dos transtornos de ansiedade, psicose e os subtipos de psicose. O que você vem fazendo atualmente?
Sim. Inclusive, nós, como o professor Jeffrey apresentou, temos a intenção de desenvolver esse protocolo, né? Nós, inclusive, estávamos no trabalho da elaboração desse protocolo para o tratamento de uma série maior de pacientes com esquizofrenia com o uso de clonazepam. Também desenvolvemos um protocolo para o uso do clonazepam na fibrilação atrial, né? Aí já não ligado à psicose, mas também é uma outra iniciativa que nós temos a intenção de desenvolver. Tudo ficou um pouco no ar, né? Assim como os nossos encontros aqui por conta do Covid, então já temos isso constituído e temos a intenção de desenvolver. E também, felizmente, graças a essa proximidade com o professor Jeffrey, eu tenho trabalhado no campo da genética com a professora Dolores Malaspina, e temos uma amostra de pacientes com psicose avaliada, inclusive quanto às comorbidades da psicose, né? Inclusive uma porção dessa amostra é do Instituto de Psiquiatria da UFRJ, de São Luís do Maranhão, aqui de Campo Grande, então é um estudo multicêntrico em parceria com a professora Dolores, e nós teremos a oportunidade em breve de pesquisar as relações entre essas comorbidades e alguns polimorfismos, algumas variações genéticas, assim que tivermos os resultados dessas análises disponíveis. Então, sim, estamos aqui continuamos aqui nessa trajetória científica de investigação da ansiedade e da psicose.
Yes, Jeffrey, do you want to say something?
Oh, I sent a note to André for him to take a quick look at.
I want to thank you, Jeffrey, very much for your participation in this meeting. It was a pleasure to have you here. André, muito obrigado. Parabéns pelos livros. Congratulations, Jeffrey, for the books. E eu quero convidar a todos para na próxima sexta-feira nós faremos um centro de estudos em homenagem ao professor Miguel Chalub, que infelizmente nos deixou recentemente, com muita saudade, um professor muito importante para todos nós, influenciou toda uma geração de psiquiatras, psicólogos, psicanalistas, um grande médico, uma grande pessoa, uma pessoa muito querida, e eu espero então todos na próxima sexta-feira às 10h30. Thank you, Jeffrey. Thank you, André. Obrigado a todos por nos assistir. Até logo. Bye, bye.
Muito obrigado. Thank you, Jeff. See you.
Obrigado.
Thank you.